Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
You know, in orthopedics, a shattered femur is just a shattered femur. You look at the x-ray, you see the displacement, you pull out the intramedullary nail, and you fix it.
Right, the pathology perfectly matches the imaging.
Exactly, which matches the patient's pain. But you step into the world of foregut surgery, and that logic completely falls apart.
Oh, totally.
I mean, you can have a patient sitting in your clinic screaming in agony with textbook heartburn, and their esophageal mucosa is perfectly pristine. On the flip side, a patient with zero symptoms might have acid silently obliterating their distal esophagus. Welcome to the counterintuitive, often frustrating world of antireflux surgery.
It is the ultimate diagnostic paradox, really. You're dealing with an anatomical zone where the subjective patient experience and the objective physiological reality frequently operate in, alternate universes.
Which is exactly why we're dedicating this deep dive to the objective data. If you're a surgeon or a doctor listening right now, this is custom tailored for your clinical practice. We're getting deep into the physiological weeds of preoperative testing today.
But before we get to the data, we should probably throw out the mandatory disclaimer.
Right, yes. This content is for reference only, and clinicians must always follow local guidelines in clinical practice.
Yeah, that is a non-negotiable baseline. We're analyzing the physiological principles and the latest consensus data, but your local clinical pathways and multidisciplinary team protocols dictate your actual operative decisions.
With that established, let's look at the stack of sources we've got today. We're pulling directly from current clinical guidelines, heavily featuring the British Society of Gastroenterology consensus, alongside some of the latest surgical literature on preoperative testing.
It's a lot of dense material.
It is. And our mission today is to decode those dense, 15-page preoperative reports, specifically combined pH impedance and high-resolution manometry. We need to answer the clinical bottom line. Who actually benefits from a surgical wrap, and how do you tailor that operation? Okay, let's unpack this. When you are looking at that patient's chart, you have to answer 3 fundamental questions before you even think about booking or R time. First, is the reflux objectively abnormal? Second, can the esophagus clear a bolus against a new wrap? And third, is there a primary motor disorder hiding in the background?
Those 3 questions basically form the firewall that protects both the surgeon and the patient. I mean, historically, we relied on a robust clinical history and maybe a quick endoscopy to look for esophagitis.
Right, just a quick look around.
Exactly. But the modern consensus is absolute here. Subjective symptoms are an inadequate foundation for irreversible anatomical alterations. Objective physiological testing is mandatory.
So let's tackle that first question. Proving the reflux is objectively abnormal, the instinct is to just trust the patient, right? If they're charting an 8 out of 10 for daily heartburn, it's so tempting to assume the acid is just flowing freely.
It is, but the correlation between perceived symptom severity and actual mucosal acid exposure is shockingly poor.
Wait, really? Shockingly poor.
Yeah, the discordance is staggering. The visceral sensory pathways in the esophagus are highly complex. You can have hypersensitive afferent nerves firing off pain signals at a completely normal physiological level of acid.
Oh, wow.
And conversely, you can have a patient with Barrett's esophagus whose sensory nerves are so blunted by chronic damage that they feel nothing, even while their mucosa is actively remodeling.
That makes sense.
That is why objective testing, specifically pH or combined pH impedance monitoring, is required, even if they have a classic response to proton pump inhibitors.
Okay, let's get into the mechanics of that testing. We are looking for the speeding camera metrics, not the witness reports. So break down the traditional 24-hour catheter or wireless capsule data. We all know the core metric is AET, or acid exposure time. But how strictly are we interpreting these percentages today?
Well, AEP is the foundational metric. It's the total percentage of time the pH drops below 4.0, measured exactly 5 centimeters above the proximal border of the lower esophageal sphincter.
Okay, and the cutoffs.
When the patient is off PPIs, the thresholds are really rigid. Less than 4% is definitively normal. Between 4% and 6% is the borderline gray zone. And anything greater than 6% is strictly, unequivocally abnormal.
Let me push back on something that always comes up in these reports, the Demeester score.
Yeah.
Because we have this precise ADT percentage now. We have advanced impedance metrics. Isn't the composite Demeester score basically a relic from the 1970s? Why is a score greater than 14.7 still cited as a primary surgical benchmark in the modern guidelines?
It's a fair critique, and trust me, it is heavily debated. But the Demeester score survives because it provides physiological context that simple AET just lacks.
How so?
AET just gives you total duration. The Demeester score mathematically penalizes specific patterns of reflux, most notably supine reflux. Physiologically, supine reflux is vastly more destructive than upright reflux.
Oh, because when you're lying down asleep, you lack the gravity required to clear the bolus.
Precisely. And you lack the salivary bicarbonate production to neutralize the acid. So a high Demeester score tells the surgeon that the reflux isn't just happening, it's happening during the most vulnerable, defenseless periods of the patient's day.
That shifts the perspective entirely. It's not just the total volume of the flood, it's the timing of it. But standard pH testing only measures the acid, and we know that's incomplete, which brings us to the impedance upgrades. This is where we measure non-acid or weakly acidic reflux. How exactly is the impedance catheter pulling this off physically?
It's pure biophysics, really. The impedance catheter has multiple metal rings spaced along its length. It constantly measures the electrical resistance, the impedance of the space between those rings.
Okay.
The esophageal mucosa normally has a relatively high baseline resistance. But when a liquid bolus enters the esophagus, well, liquid conducts electricity much better than empty space. So the resistance plummets.
And because there are multiple sensors, the software tracks the direction of that resistance drop, right? If it drops from top to bottom, the patient just swallowed water. If it drops from bottom to top, it's a retrograde reflux event.
Exactly. And by combining that physical liquid tracking with the pH sensor, we can categorize every single event. Is it acid? Is it weakly acidic? Is it a pocket of alkaline gas?
So it catches what we used to miss.
Totally. A traditional pH probe might miss 50 episodes of high-volume, weakly acidic fluid splashing into the distal esophagus. Impedance captures the total physical burden of the reflux aid.
Okay, so the thresholds for those total physical events are 73 or more abnormal episodes off PPIs and 48 or more on PPIs. But just having fluid in the pipe isn't enough to justify a fundoplication. We have to prove causality. We need to prove that specific fluid is triggering that specific patient's pain.
Yeah, this is arguably the most critical part of the entire report symptom association. When the patient presses the symptom button on their monitor, the software runs a correlation matrix against the physical reflux events. You're looking at two key statistical markers here, the symptom index, or SI, and the symptom association probability, the SAP.
Now, the SI seems pretty straightforward. It's a simple fraction. If it's 50% or greater, it means at least half of the times the patient pressed the pain button, the probe was actively detecting a reflux event. But the SAP is trickier. It needs to be 95% or greater. Walk us through the mechanics of the SAP.
So the SAP is a statistical calculation. It's essentially a Fisher's exact test applied to clinical data. The 24-hour testing period is chopped up into 2-minute windows. The software analyzes every single window to see if reflux occurred and if a symptom occurred.
Okay.
An SAP of 95% means there is a 95% statistical probability that the patient's symptoms and the reflux events are not occurring together by random chance.
All right, let me throw a complex clinical scenario at you. You have a patient who is entirely refractory to PPIs. They're on dual therapy, max dose, and still totally miserable. Intuitively, a surgeon might think, well, the medical therapy has failed, so it's time to escalate to a mechanical surgical fix. But what specific data point on that impedance report gives you the green light that surgery will actually succeed where the pills failed?
That scenario right there is the classic trap of foregut surgery. Operating just because PPIs failed is a recipe for a post-operative nightmare.
Because if they're truly refractory to PPIs, it means the acid is already neutralized.
Exactly. If they're still having symptoms, you must look at the impedance data. The golden ticket is finding ongoing high-volume, non-acid liquid reflux combined with a highly positive SAP.
Because if the volume is still there, it means the physical distension of the esophagus is what's causing their pain, not a chemical burn.
You nailed it. The problem is mechanical. The LES valve is physically incompetent, allowing a massive volume of neutralized gastric juice to mechanically stretch and irritate the lower esophagus. PPIs cannot fix a broken valve.
Right. Pills don't fix plumbing.
Exactly. But a mechanical problem responds beautifully to a mechanical solution, like a fundoplication. Conversely, if they're refractory to PPIs and their impedance shows zero volume reflux and a negative SAP, their pain is not GERD. Do not operate.
Which perfectly transitions us to the second phase of the workup. If the impedance probe is our diagnostic camera, the high-resolution manometry catheter is our structural stress test.
Right.
Because once you've proven that fluid is washing back up, the surgical instinct is to build a dam. tighten the valve.
Thing.
But you can't just slap a 360-degree high-pressure zone onto a failing pump. The esophagus actually has to push a bolus of food through that new surgical resistance.
Right. High-resolution manometry, or HRM, is the plumbing inspection. Without it, you're basically flying blind into a potential functional disaster.
Let's break down the physics of the HRM report. Surgeons are used to looking at those colorful topographical pressure maps, the Klaus plots. What are the mechanical truths we're extracting from those colors?
Well, the topographical plot maps pressure over time and space. The warm colors, like the reds and purples, are high pressure. The cool colors, the blues and greens, are low pressure. The first thing you establish is the baseline architecture. Where exactly is the LES, how long is it, and what's its resting tone?
Got it.
Then we analyze the dynamic function during a wet swallow, focusing on the IRP, the integrated relaxation pressure.
I want to dig into that word integrated for a second. Why isn't it just a simple minimum relaxation pressure? Why do we have to integrate it over time?
That's a really vital nuance. When you swallow, the LES relaxes for about 10 seconds to let the food pass. But during those 10 seconds, the patient is still breathing. Every time they inhale, the crural diaphragm, which surrounds the LES, contracts and spikes the local pressure.
Oh, so if we just looked at an average or a maximum, the breathing artifact would make it look like the valve never even opened.
Exactly. The integrated relaxation pressure calculates the average of the lowest 4 seconds of pressure during that 10-second window. It effectively edits out the diaphragmatic interference, giving you the true isolated relaxation profile of the sphincter itself.
So if the IRP is elevated, it means the door isn't opening properly. The bolus is bouncing against a locked or partially locked valve. But what about the pump itself? How do we measure the vigor of the esophageal body squeezing the food down?
For the esophageal body, we look at the DCI, the distal contractile integral.
Yeah.
This incorporates the amplitude of the squeeze, the duration of the squeeze, and the length of the esophageal segment involved.
I always visualize the DCI like squeezing a tube of toothpaste from the bottom up. If you just grab the middle of the tube and squeeze really hard, high amplitude, but you don't coordinate the squeeze from bottom to top, the toothpaste goes nowhere.
That is an excellent visualization, actually.
Thanks. So the DCI proves that the squeeze is not only strong enough, but perfectly sequenced to push the bolus forward.
Right. And according to the Chicago classification guidelines, manometry served 3 indispensable roles here. First, to definitively exclude primary motility disorders. Second, to map the exact LES location so the pH probe can be positioned accurately. And third, to characterize the peristaltic vigor to dictate your surgical tailoring.
Let's talk about that surgical tailoring. Say you have a patient with proven GERD, their DCI is robust, their swallows are 100% effective, and their IRP is normal.
That is a green light for a full 360-degree Nissen fundoplication. The pump is strong enough to easily overcome the resistance of a tight wrap.
But what if their Chicago classification comes back as ineffective esophageal motility, or IEM? They have a low DCI, maybe 60% or 70% of their swallows are weak or completely fragmented. Does that mean we abandon surgery, or is this where we compromise with a partial wrap, like a 270-degree toupee or an anterior door?
It's not so much a compromise as it is an engineered balance. If you put a Nissen on a patient with IEM, you will likely cure their heartburn, but they'll end up in your clinic unable to swallow solid food. Severe dysphagia. Right. So you tailor the barrier. A partial wrap provides a lower resistance valve. It significantly reduces the reflux while remaining permissive enough for a weak esophagus to push the bolus through.
But let's look at the red flags. What happens when the manometry reveals an elevated IRP and 100% failed peristalsis? What if the report reads achalasia or esophagogastric junction outflow obstruction?
That is a hard stop. You abort any plan for an antireflux wrap. If you perform a fundoplication on an undiagnosed achalasia patient, you will catastrophically obstruct their esophagus.
Right, because they need specific achalasia therapy.
Exactly, like a Heller myotomy or a POM procedure to destroy the LES muscle, not reinforce it.
Here's the part that always baffles clinicians, though. How frequently do these severe spastic disorders masquerade as standard reflux? I mean, you'd think a patient with achalasia would complain of food getting stuck, not acid heartburn. How are they getting mislabeled as refractory GERD?
It happens far more often than we'd like to admit. And it comes back to the visceral sensory pathways. In early achalasia, food and saliva pool in the distal esophagus because the LES won't relax. That retained food ferments.
And creates lactic acid.
Right. That fermentation physically burns the mucosa, creating a sensation that the patient, and often the primary care physician, interprets as standard acid heartburn. Furthermore, the sheer physical distension of the esophagus stretching against that trapped food triggers chest pain that perfectly mimics severe reflux.
So if you just rely on their symptoms and maybe a quick endoscopy that shows some mild inflammation from the fermented stasis, you could easily walk into the OR thinking you're fixing a floppy valve when you're actually tightening a valve that's already clamped shut.
And that is precisely why a preoperative manometry report is your absolute safety net.
All right, so we have our structural map from the manometry, and we have our chemical and volume data from the pH impedance. Now we arrive at the clinical crossroads. Let's build a practical decision matrix for the surgeon reviewing these reports. Let's skip the easy slam dunk cases. We all know what to do with abnormal AET and perfect motility. I want to dive into the treacherous gray zones.
Okay, let's do it.
Scenario A. A patient has completely normal acid exposure time, fewer than 40 reflux events total, but their SAP is 100%. Every single time a tiny physiologically normal drop of fluid enters the esophagus, they hit the pain button.
Well, this points squarely toward reflux hypersensitivity or functional heartburn. The mechanical barrier is actually working fine. The volume of reflux is normal. The issue is neurological.
The wiring, not the plumbing.
Exactly. Their afferent sensory nerves are hyperreacting to normal physiological events. The guidelines advise extreme caution here. If you operate to fix a mechanical problem that doesn't exist, the patient will still feel the pain postoperatively because the sensory nerves are still misfiring.
What about scenario B? The AET is stuck right in that borderline 4% to 6% window. They have typical symptoms, the motility is fine, but the AET just isn't definitive. Do you look for tiebreakers in the impedance data?
Absolutely. This is where you rely on a multidisciplinary team discussion, and you look at advanced impedance metrics. You look at the total number of reflux events, if it's over 80, that pushes you toward a positive diagnosis. You also look at MNDI, the mean nocturnal baseline impedance.
I'm glad you brought up MNBI. Explain the physiological mechanism behind that metric. Why does the baseline impedance during sleep matter?
Remember how we discussed that healthy mucosa has high electrical resistance?
Yeah.
Well, when the esophagus is chronically exposed to acidic or weakly acidic damage, the tight junctions between mucosal cells break down. You get dilated intercellular spaces. Those microscopic spaces fill with fluid, which conducts electricity.
Oh.
So a low MNBI during sleep, when they aren't swallowing, tells you that there is chronic microscopic mucosal damage holding onto fluid, even if the gross endoscopy looked totally normal. A low MNBI can tip a borderline AET case firmly into the abnormal reflux category.
That is a phenomenal piece of diagnostic detective work. So rather than looking at these reports as an oral exam checklist, surgeons should approach them as a cohesive physiological narrative. The pH tells you if the fluid is escaping. The impedance tells you the physical volume and the microscopic tissue damage. The symptom association tells you if that specific fluid is firing the pain nerves. And the manometry tells you if the plumbing can handle the structural repair.
Right. It transforms surgical decision-making from a subjective art based on patient complaints into a highly precise, tailored science.
So what does this all mean for the future of foregut surgery? We've mapped out the physical pressures, the electrical resistance, and the chemical exposures, but let's look at the horizon here.
Well, if we focus on those gray zones we just discussed, particularly the reflux hypersensitivity patients, it raises a profound question about our therapeutic limits. If a patient's pain is driven by an overactive sensory nerve interpreting normal physiological events as acid attacks, are we reaching the end of what mechanical surgery can accomplish?
That is the ultimate question. We are essentially trying to solve a software glitch with a hardware upgrade. Can a perfect, mathematically precise surgical wrap ever quiet down a hypersensitive nerve?
It's doubtful. And that is the true frontier of foregut medicine right now. Understanding the brain-gut axis, recognizing the precise moment when a patient stops needing a mechanical barrier surgeon and starts needing neuromodulators like tricyclic antidepressants or SSRIs to directly calm down those sensory pathways.
Yeah.
Because the most beautifully tailored to-pay fund application in the world will not cure a misfiring afferent nerve.
That is a massive paradigm shift to mull over the next time you are staring at a borderline impedance report with a highly positive symptom association. It forces you to ask, is this a plumbing problem? Or is this a wiring problem?
It really changes how you look at every patient.
Listen, if you like this deep dive, do not forget to share it with at least one of your colleagues or friends to spread the word. It really helps us grow the show.
Definitely.
Also, be sure to check out our YouTube and other social media pages for more in-depth content. And definitely dive into our previous season and episodes. We have some incredibly relevant clinical topics waiting for you to explore. We'll see you on the next one.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.